All right, good afternoon. We're going to go ahead and get started. Hello, everyone. Thank you so much for joining us. I'm Vincent Atchity, President and CEO of Mental Health Colorado. The Equitas Project is our national initiative to disentangle mental health and criminal justice. Care Not Cuffs is our campaign to build public support for efforts to respond to health needs with health care, as opposed to with incarceration and punishment. Thank you all so much for joining our virtual National Rural Summit series on mental health and criminal justice. This free conference, hosted by the Equitas Project in partnership with the Law Enforcement Assisted Diversion Support Bureau, offers panels each Friday afternoon for 3 weeks to focus on rural and frontier diversion efforts and the unique roles and challenges of rural and frontier leaders in disentangling mental health and criminal justice. Before we get started, I want to just thank our partners again at the Lead Support Bureau and at the National Center for State Courts, as well as Emma Troten and Adam Goss, our staff from our Care Not Cuffs initiative here at Mental Health Colorado. I also want to acknowledge the very generous support for the Equitas Project from the David and Laura Mirage Foundation. All of our advocacy work is possible thanks to the generosity of partners and allies. Thank you so much for your support and donations. During our talk today, we've got a Q&A section that you can use to ask questions, and there'll be some time for those responding to those questions at the end. This entire session will be recorded and will be available on our website by the end of next week. And we can put a link to the website in the chat. And with that, we're going to go ahead and get started. It's my pleasure to introduce our panelist. Our first panelist for today is Veronica Dietz, who's the Director of Crisis Services at the Carroll County Health Department in Carroll County, Maryland. Thanks so much, Veronica, for joining us today. I'm going to go off screen so that you got the stage to yourself, but we'll be here with you and we'll help moderate questions at the end.
Great, thank you so much. I'm going to quickly share my screen and hope that you all can see that.
Yeah.
Okay, excellent. So good afternoon. I am really excited to be here and to share with you all today. I had a chance to speak with Vincent several weeks ago, and the idea of, he used the term, the disentanglement of criminal justice and mental health, and it just hit me like a ton of bricks. I loved the thought of it, and it's definitely the passion that we have here in Carroll County, Maryland. So I was excited to be able to come and to share and talk a little bit about what we're doing here and our little corner of the world with you all. So I'm just going to talk a little bit about how our jurisdiction and how our community is really leveraging and kind of capitalizing on collaboration. When you're in a small community, when you're in a community that's in general considered rural and not necessarily making news headlines as often, it can be hard to get funding or hard to find ways to get things done. And so what we really have learned to do, I hope to share just a snippet of that with you all today. So again, I'm Veronica Dietz. I am the Director of Crisis Services here at the Carroll County Health Department in Westminster, Maryland. So Maryland it's a small state here in our country, all the way over on the East Coast. So I'm actually coming to you at the end of the day, at the end of our week. You can see there a map of what you're looking at. Our county is there in blue, kind of highlighted. Marylanders we love our state. We love our flag, especially. We love crabs in Old Bay. And in our neck of the woods specifically, we love agriculture, and we are still very much considered, though we're only about 35 miles northwest of Baltimore, we're still very much considered a rural community. So that presents on its own, in itself, a lot of challenges for meeting the needs of people with behavioral health issues. I do want to just kind of give a bit of a caveat in terms of language. I will use the term behavioral health. In our jurisdiction, we're really working to be a more integrated community. And so we really try to look at behavioral health issues as both mental health and substance use issues under a combined umbrella. So I'll use the term behavioral health, which will mean those things. So this is the Carroll County Health Department. This is where I work. Our bureau, we are made up of 4 bureaus here at the Health Department, all focused on public health and public health initiatives. The Bureau of Prevention, Wellness, and Recovery is the bureau that I work within. And that bureau also serves as our local behavioral health authority, the local arm of the larger behavioral health administration through our Maryland Department of Health. Again, a big part of what I do, I'm going to talk specifically about the LEAD program today, but some of the other pieces that I oversee and monitor include our reentry social workers working inside of our local detention center. I oversee and support a team of individuals who provide same day, next day assessments and access to services. We provide school screenings for substance use issues for our public school system, as well as overseeing and monitoring the contract that we have with our mobile crisis team vendor. So we recently were able to engage a mobile crisis team. I'll talk a little bit about that. But the biggest piece that I'm doing right now, and the piece that's taking a lot of my attention and energies, is our LEAD program, our Law Enforcement Assisted Diversion program. And for that program, I get to serve as the supervisor for our services team, but I also serve as the program manager for our LEAD team. So again, we are in Carroll County, Maryland. Some statistics there for you so you have an idea of what you're looking at. We're a population of about 172,000 people, just shy of 173,000. The majority of those people live in the unincorporated part of the county, right? So our county seat is Westminster. That's where our office is located. That's where a majority of the services that are provided within our community are centralized. Really densely centralized, but the large number of people that we're interacting with or serving as it relates to other issues are in these kind of broad outside areas. Again, 453 square miles, that's what we're talking about. Not a huge community. We are a fairly wealthy community. Our median income of about $99,000. And within the county, only about 5% of those people are living at the poverty level. You can see the racial composition of our community. You know, we are majority, the community is majority Caucasian, with lower incidence or lower percentages of Black and African American, Hispanic, Latino, Latinx community, AAPI. So again, 50% of our county is used for agriculture. That's our #1 business here in Carroll, and we are still considered a rural community by the state of Maryland. We work a agriculture preservation initiative here. Our goal in Carroll County is to have something like, I think it's 100,000 square miles of agriculture preserved. And they do that through funding. And so that's a big initiative here. And that's something that the community values, is the idea that we are this kind of quiet rural community. And again, Westminster is the county seat here. So you'll see that's just a little kind of snapshot of our quaint Main Street downtown. That's actually the exact center of our town, the intersection of Liberty Street and Main Street. So tell you a little bit about Westminster. So Westminster, Maryland is a population of just under 20,000 individuals in 6.7 square miles. You'll see as we come into Westminster, in terms of Carroll County, that the median income does drop significantly. The percentage of people living in poverty does increase, and the racial composition does change a bit. So while Carroll County at large is considered more rural, Westminster itself is seeing some challenges that are not unlike, I've talked with our assistant chief or deputy chief at Westminster Police Department, and he talks a lot about how Westminster is seeing some of the same problems that will exist in bigger cities. And one of the biggest issues that we wanted to begin to tackle really was the opioid epidemic and the overdoses. In Carroll County, at the height of the opioid epidemic, FY18, we had 513 overdoses. More than half of those overdoses happened within the city limits. And so the police chief really had some significant concerns and really wanted to tackle this issue head on. He recognized very early on that This was not a problem we were going to be able to arrest our way out of, that individuals who had behavioral health issues and, who were engaging in criminal, or I hate to say criminal behavior, but who were engaging in arrestable behavior, really were struggling with their behavioral health issues. And no matter how often they were arrested, they were going into incarceration, but returning to the community, and the issues were never really being resolved. So he really began to explore and champion some, out of the box ideas for addressing the concerns within the city limits. In Carroll County, one of the things that we really do pride ourselves on, because we are kind of this smaller, unassuming community, not very well funded, not hugely populated, a fairly safe community. We're not making lots of headlines. And the kinds of headlines that, Baltimore City has a tendency to attract, we're not really seeing those kinds of issues. But we do have other things that are going on that we do need to address. And so we have found very early on that the best way that we can address some of the issues that we're struggling with is through collaboration, communication with, various disciplines, and having leaders at tables where we can discuss ideas and what we can do versus what we can't do. And so it is not an uncommon thing to see law enforcement at a table with criminal justice, Office of Public Defender, those in public health, those who are providing behavioral health supports, those who are representing the local hospital. Carroll County is one that we have one local hospital. So we really do have to find ways to communicate and collaborate together in order to get things done, because we're the only game in town. So we learned very early that we're not going to be able to arrest our way out of the opioid epidemic. We learned very early that people with behavioral health issues were not just going to magically disappear. We all know the story. I'm assuming we all know the story anyway, that the idea that deinstitutionalization as a result of the, Community Health Act of 1963, just lots and lots of people returning to communities where mental health needs were not actually being met. Funding never followed them. And so we learned very quickly that we needed to have some criminal diversion programs in place. And so in 2007, Carroll County established and implemented its first drug treatment court. So Carroll County Drug Treatment Court was established and began engaging individuals who needed that level of support. In 2012, following the integration of our mental health and substance use bureaus, we integrated into the local behavioral health authority, our diversion work group was established. So this work group had members of all of those community partners sitting at a table, talking about the needs that the community had in terms of diverting people with behavioral health issues. Oftentimes we would have our reentry case managers and social workers there, presenting cases for people who were engaging with criminal justice because of their behavioral health needs. And how can we get those individuals out of incarceration and into community resources? So through that diversion work group in 2014, Carroll County established and graduated its first class of crisis intervention team officers. We were excited to graduate 11 officers, including 2 correctional deputies, into our crisis intervention team program. For those who are not familiar with the CIT program, it is a collaboration between community mental health, community advocacy, and local law enforcement to divert individuals out of unnecessary emergency petition use and unnecessary incarceration into resources because of the behavioral health needs that are being exhibited, not criminal in nature, but needing some support. So we graduated 11 officers and have since, to date, we're at about 100 CIT trained officers throughout the county in local colleges, as well as several dispatchers. So we're excited about that program. In 2016, the Carroll County State's Attorney's Office initiated what they were calling the Early Intervention Program. So they brought on what they titled a substance use education specialist or liaison. He is an individual who is also sitting on our lead team. And this individual is a person in long-term recovery. So he is a peer. And he's also someone who is a local business owner and who speaks pretty regularly in the recovery community. He works alongside of the state's attorneys, presenting not only information to parents and community members about substance related issues, but he also works with these individuals who are kind of first time offenders, someone who's committed their first crime, they've been arrested. If they can go through this program successfully, those charges that they were initially arrested on can be expunged. So this was their initiative that they rolled into the community and began engaging some individuals in. And then in 2018, Carroll County was one of 4 counties in the state of Maryland. There are 24 jurisdictions in the state of Maryland, 23 counties, including Baltimore City, 24. And we were one of 4 communities that did not have any form of crisis response service or mobile crisis teams. So we were able to pull together some money that had been set aside for crisis response. That wasn't quite enough money that we needed to establish, but the county, in good faith and recognizing the need for this in our community, put forth some additional funds. And then we used some additional funds from our opioid operational command center that was established through the governor's office. Shortly after our current governor took office, he declared a state of emergency related to the opioid epidemic, and that funding was able to then be released. Those funds we were able to put together, and in 2018 establish a mobile crisis team. So we very much believe in diversion, and we very much try to put our money where our mouth is in terms of let's really work on this. But we learned about this program called Law Enforcement Assisted Diversion in 2019 at a statewide meeting. Our office learned from a representative from what was then called the Governor's Office of Crime Control and Prevention, is now the Governor's Office of Crime Prevention, Youth and Victim Services, came and presented and talked about this agency called the Lead Support Bureau, and presented this program where it's another tool in the toolbox for law enforcement. It's a way to engage individuals who are kind of chronically interacting with criminal justice, but it's really based on their unmet needs. And through that, we really began to explore this. We came back to our community. We hosted a large meeting, a stakeholder meeting with all of the community, policing agencies and our staff and our health officer. And we just discussed, did we think that this is something we could use in our community? And so we did submit through the Maryland Department of Health's Office of Harm Reduction Services, a grant. At the same time, the governor's office was submitting for what was called the COPE grant and is now called the COSAP grant. And we became a sub-grantee of that grant. At the time, we were one of 3 kind of exploring agencies. Baltimore City had already had a lead program established. Washington County, which is our neighbor to the west of us, about 2 counties over, had been granted some funds and they were getting ready to roll their program out, and we had begun to explore. So we, with that COSAP grant, we're able to kind of solidify our program for the next 3 years and really begin to work on establishing that. So the funding that we pulled in through COSAP and through the harm reduction grant really helped us to establish a team. Primarily it went to providing the funds to create our services team. That team includes a clinical case manager who is a credentialed social worker who provides intensive case management, but also kind of provides some clinical support and assessment. And then we also hired a peer recovery specialist. This is a young man who lives and works in our community, has been a member of our community during his times in active use, but also at times in recovery. He is currently 6 years in recovery. And together, this team works with our lead participants pretty intensely. And we're going to talk a little bit about what that looks like and why we really like the lead program. But that's primarily where our funding went. And then with the great support of the Lead Support Bureau with their team, and we had Chief Cox out to Carroll County and into Maryland and just had really wonderful talks with our law enforcement agencies. They really did help us in the development and implementation of our team and our program. So we were excited to kind of begin to roll that out. And so, of course, we were all set and ready to pull the trigger, the proverbial trigger. And unfortunately, COVID hit. And so we were initially planning to roll out our program in March of 2020. That did not happen. We had to push back to August, but we were able to roll out August of 2020. We had trained 3 officers who were going to be our power users, and then of course, our services team, and then all of the ancillary members of our lead team were also trained in the program. We had initially anticipated being able to engage, about 25 people, not a large number, but what we found as a result was that we really were getting much fewer. I mean, partly because of the pandemic, but also just because of the intensity and because of the nature of the program, we ended up really only engaging, probably in the first year, only about 5 or 6 participants. But these were participants that were requiring a significant amount of support, folks who had significant transportation issues, significant housing issues. And through our programming, we're able to engage some of these folks, and we'll talk about what kinds of services were provided and what that looks like. The beauty of our program is that we are able to be co-located at the police department. Again, the police chief was a huge champion of this program and really felt like having the services team embedded with law enforcement would make a difference in being able to connect people immediately to the team. So an individual can, if they're interacting with someone in the community, can immediately call our services team and they can respond to the location, or they can bring the person back and turn them over to, hand them off to the services team. So it really looked very different. The idea, they're not necessarily being cuffed and taken to central booking. They're being brought in and connected with a services team immediately. Law enforcement kind of walks away at that point once they're connected. So who's at our lead table? So I mentioned earlier that we are a county that collaborates, and we really, really believe in that. So our lead team has 2 levels of individuals that are participating, but from various agencies. So we have representatives from Westminster Police Department, from the Carroll County Sheriff's Office, from the Carroll County State's Attorney's Office, from the Office of Public Defender, Parole and Probation, our Health Department services team. They are employees of our Health Department. And then I'm representing the local behavioral health authority as the program manager. But we have 2 levels of interaction. So we have our operational work group, which is all of the individuals that are operationalizing. They're putting, boots on the ground, what we're doing. And then we have our policy coordinating group. Those are the higher level individuals, the decision makers, the folks that are looking at our policies and ensuring that that the goals of the community are being met through, and really the ideals of the community are being met through the policies that we've created. And there are formal MOUs in place. Our team, has a full MOU in place with all of the various folks signing off to participate in the program. Okay, so let me talk a little bit about why we like LEAD. So one of the biggest things about LEAD is we really love that it is a harm reduction approach. We're not necessarily expecting people to be, sober or to abstain from using. It's a harm reduction approach. We recognize that people are going to change when they're ready, willing, and able, and they're at various stages of change. And so this allows us to help individuals work on implementing things that will keep them alive until they're ready to make the next step into recovery. We love that it takes a trauma-informed approach. It's information that we find incredibly vital to share with our community and educate our community on how impactful trauma can be and has been to individuals with behavioral health issues. This is an intensive street-based outreach program. So when I talk about our services team being embedded at the police department, their offices are there, but I will tell you it is rare that you will find them there. You will much more likely be finding them in the community, catching up with individuals, driving out to a person's home, picking a person up and taking them over to a food kitchen or to the hospital for, follow-ups or to, doctor's appointments. They are in the community pretty regularly, going out and catching up with people. What we love about LEAD is that it's not a single agency ownership. Everybody takes ownership of this program. It is a collective program. It's not the health department's program. It's not the state's attorney's program. This is a Carroll County program. We collectively buy in, we collectively participate. And again, it allows for that ongoing collaboration. Everybody at the table is hearing the same update on each participant. We're hearing all of the milestones that are being achieved. We're hearing the setbacks that are happening. Everybody at the table has input. So a few highlights about our program since we've started. We've engaged and enrolled 13 individuals total, but currently have 12 engaged. In the last few months, we did lose one participant to they withdrew from the program, just some of the limitations of the team and his specific needs he felt like were not being met. So it gives us some room to explore kind of if there's something we can be doing differently. But overall, participants are engaged in really utilizing the service. Our longest engaged participant, about 23 months, which is one of our first, continues to engage with the services team, despite the fact that she does not have ongoing, criminal justice involvement. She's still utilizing the support of the team. And the team continues to support participants who have received services but have gone outside of our jurisdiction. Some of our participants do decide to get connected with treatment services. And when they do that, they will sometimes be taken outside of our jurisdiction. Our team continues to connect with them to ensure they're doing well. And if there's something else that we can support them with, we do. Some data. Fiscal year 21, we had one arrest diversion referral, and we had 4 social contact referrals. We find that often that we're having fewer of the arrest diversions and more social contact, which again gives us some room to talk a little bit about what we can be doing differently if we need to be doing anything differently. 2 of the participants that we had during fiscal year 21 did get arrested for new crimes, but we can say that those new crimes, those new arrests were behavioral health related. Again, because we're not saying abstinence is required, we are finding sometimes that people will continue to engage in behavior that does end up resulting in new charges. But none of our participants were arrested for a violation of probation, which I think speaks to the idea that intensive street-based outreach, individuals are connecting with our services team and they're helping them to do the follow-up that they need. 5 of our participants were seen in the emergency department. We had a couple who had some pretty significant medical issues. So they were really working to kind of get those medical issues under control. And we did have 4 people experience subsequent overdoses. Again, this is not a program that expects or requires abstinence. However, those 4 people that experienced overdoses continued to stay connected to our team. Because of the intensive street-based outreach, because it is a collaborative effort, and because we're collaboratively and collectively supporting them, they did not shy away, they did not shame away from our team, they continued to engage. And 4 of our participants were able to be connected with the medication-assisted treatment program. Again, another harm reduction approach. So I want to talk a little bit as I wrap up about 2 of our program participants that we can talk about data, and data certainly gives us something solid, but in our community, since we are so small and since our numbers are so small, the numbers don't seem as significant. But when we talk about them anecdotally, when we talk about the experience, we can tell you this is where we're seeing success. So one of our first participants, I think he was actually our second participant referred, was a young man in his mid-30s who was really struggling with an opioid addiction. And he just really was having a difficult time, not using. It's just really what it was. He was having several calls for service. In 1 month, I think we counted 20 calls for service by the local PD. He was engaged in our lead program, began engaging with the peer recovery specialist and the clinical case manager, really made a connection. And while he continued to struggle and did, get additional charges, in the nearly 2 years that he has been engaged, we can say that he has dramatically reduced his calls for service. And in fact, in the last 6 months, he may have had maybe 1 or 2 calls for service versus prior to that, 20 a month. He's doing very well. He has stayed connected with work. He has been able to get a driver's license and a vehicle, and is now working on moving into more stable, independent housing. So we count that as a success, though he has not discontinued use completely, and still sometimes struggles with his opioid use addiction or use disorder. This is a case that I think is probably the most heartwarming. My clinical case manager shared this with me a couple of weeks ago. One of our participants who was referred to us in December of last year really was struggling, lots and lots of calls for service, mostly disorderly, mostly because he was getting into arguments with his landlord or the neighbors or people in the community. Really struggling with an alcohol use disorder. He engaged with our team. He would sometimes call the team 20 and 30 times, leaving messages continuously. And they just continued to work with him and work with him. And the peer began to talk with him a little bit about harm reduction, like, hey, you know, I know you're not ready to stop drinking, but maybe you can cut back some of the drinking, or maybe you can change what you're drinking. And he began to take some of that feedback. He began to consider, you know, maybe I should not drink whiskey as much and I'll just drink beer. And so he made that switch. Then he started to notice he wasn't really sleeping, he wasn't eating. And he's like, well, maybe if I'm not drinking all day, I'll be able to eat and sleep. And so he's begun to really wean himself off of some of that. Today, he's drinking from 8 p.m. until midnight, still drinking every day, but not drinking every day, all day. He is now eating, he is now sleeping, he is now engaging in mental health counseling. And all of that just based on the relationship established with the LEAD team. He really identified LEAD as a catalyst and told the case manager, LEAD has changed my life. So when we talk about this idea of disentanglement of criminal justice and behavioral health, LEAD is really, really, really a great way to do that. And you will see that individuals who engage with the team in that intensive street-based case management really do find ways to support people and keep them out of criminal justice engagement and interaction, and really working to redirect them to the behavioral health world. While LEAD wasn't designed to address behavioral health issues initially, specifically, the core values and the goals do support that. So we still have some work that needs to be done. We're working on addressing stigma and educating our community on ongoing behavioral health issues. We're working to get the buy-in from some of the community. I'm assuming that most people know what LEAD is, and so I didn't really talk about LEAD, but again, with the idea that victims of crimes need to sign off on a person's participation in LEAD. We feel that the Chamber of Commerce would be a great community partner to buy in, because we could talk with them and store owners on why it's important for people to engage in this program if they've been arrested for a crime in one of the local community businesses. We're working to expand into our sheriff's department and municipal agencies as well. And we're working to establish a community stakeholder group to continue to keep the LEAD program accountable. This is an issue that is really being discussed statewide. In 2021, there was a legislation passed in our General Assembly that established a public safety and behavioral health center of excellence with the goal of increasing treatment and reducing detention for those with behavioral health issues. So this center of excellence is really going to begin to tackle that issue head on, as well as planning the use of sequential intercept model. If you're familiar with the Samsa Gaines Institute, those intercepts where people are engaging with criminal justice and trying to find ways to pull people out of the criminal justice system. And then additionally, the state is also looking at crisis response and crisis services, trying to disengage law enforcement in those arenas. Our jurisdiction is one of 4 that's involved in this Greater Baltimore Regional Integrated Crisis System, or GBRICS for short. It is a 5-year, $5 million grant they're going to use to kind of recreate crisis response, to allow for people to be able to outreach for support and crisis services, but without having to go through 911 or go through law enforcement for that. So this issue is not going away. We are looking at this in Maryland ongoing, and I think this is going to be our topic for quite some time. So I think I probably got to about 30 minutes, if not a little bit over. So I can certainly save questions till the end to give time for the next speaker. So thank you all so much.
Thank you, Veronica, for a great presentation. We've got a few minutes. If anybody's got questions to put in the Q&A, Veronica would answer those. And I imagine you make yourself available to anybody who's interested in a follow-up conversation. You can just reach out to us and we'll connect you that way.
Yep, please feel free to share that.
I just wanted to ask about, we've had a lot of talk here in our community about the prevalence of fentanyl in the drug supply. And I don't think you said anything specifically about fentanyl. How has that affected your work? Yeah.
Well, I can tell you that since 2018, and that was probably our worst year in terms of overdoses, 2018, and we saw kind of a slow decline, and then 2020 came, and that did, the pandemic did none of us any favors, and certainly not the most vulnerable among us. We are seeing increases of it. The majority of our fatal overdoses do have some level of fentanyl interaction. It is huge. It's definitely something that we're seeing quite a bit of. It's a huge problem, and I would like to think that it's going away, but we're still tackling it.
And so one of the key features of a LEAD program is that discretion on the part of law enforcement, that they are deliberately diverting somebody toward the care that they need, as opposed to making an arrest for possessing a controlled substance. So has that changed, that discretion with regard to making those arrests changed in light of the fentanyl presence in the drug supply? And I just ask because we recently in our state made what we viewed as a terrible misstep of refelonizing possession of fentanyl, which we expect will result in an increase in arrests. It won't do anybody any good.
Yeah, it really hasn't. For our community, we really are looking at it like we recognize that we're doing a huge push in our community, and we just had a training not 2 days ago, a huge push in our community among first responders. The idea that first responders see this over and over again, right? And because this is not necessarily their area of expertise, compassion fatigue and burnout and their deep well of empathy is drying up. And so it becomes very difficult for them to find a place to care, right? And so we're doing a huge push to address stigma, to address the science of addiction, and to help to increase the depth of empathy amongst the first responders. Our program does not change that. It's at law enforcement's discretion. And I would say the majority of the people that we work with at Westminster Police Department, because we are piloting, we're not countywide, we're just at the police department. The majority of the individuals that are in our LEAD program and that are trained to divert LEAD folks get it and understand that this is an arrest is not going to make it better. So I think that we're seeing some headway, but there's still work to be done. And it really is about developing that well of empathy for folks.
Great. Well, thank you so much, Veronica. I don't see any questions coming up in our Q&A section. So I think we will just thank you again for your presentation, and remind everybody this will remain available on our website. It'll be posted up there within the next week or so. And Veronica will be available to anybody who wants to follow up with conversations about the great work that you're doing in Carroll County. Thanks so much for being with us. And with that, I'm going to introduce our next presenter panelist for today, one of our key allies and friend, Judge Jonathan Seamus, who's the Lake County judge in Lake County here in Colorado, and is here with us to talk a bit about judicial-led diversion. Thank you, Judge Seamus, for being with us today. And I'm going to hand this over to you and let you talk.
Thank you. There are lots of conversations lately of how important it is to decriminalize mental health. On the one hand, of course, no one could disagree with that idea or that ideal, but the reality is there's such an intersection between courts and court systems and court processes and people who are struggling with mental health. To me, it's absolutely positively essential to be able to recognize that, identify that, and to use those systems to try to effectuate a world in which mental health is in fact truly decriminalized. One of the things that said to me is kind of interesting is we had a survey of the Colorado bench a couple of years ago asking what is it that judges felt they needed to know? What was the gap in their knowledge base? And you would expect things such as criminal procedure, evidence, stuff like that. The second most important issue that judges felt they needed to have a better education, better knowledge, better understanding of is mental health. And so one of the things that we're doing is trying to help educate judges so they even understand what comes before them every single day. Because the reality is in law school, maybe a small handful took a class on mental health law, which is mostly about commitment, But every single day, there are people who come before us who have different issues, whether it's just mild depression or PTSD or whatever, and we have no clue of what we're dealing with. Our response is either to go to the recommendation line if we've asked for mental health evaluation and just rotely embrace whatever recommendations or findings they have, or not even do that well, simply just say, go get a mental health evaluation and they'll figure it out. Yet we have the power, we have the authority to really have a positive impact if we choose to do so. Right before this meeting, I was on a conference call with Steve Vasconcellos, who's a state court administrator. His response is, we could do amazing things in the area of mental health. We can and we should. And so you have very receptive partners who recognize there's a huge lack and a huge gap, but also an important and huge opportunity to improve what's happening. And that's one of the things in our district, in the 5th Judicial District of Colorado, I also practice in the 9th as well, that we're committed to trying to figure out how we can improve deliveries of mental health services through collaboration. The previous presenter talked about SIMS mapping. That's where we in the county started about 1.5 years ago. We have 40 or 50 agencies, and we're a very small county. But we had 40 or 50 different agencies collaborate, come together to be able to talk about, identify what's working, what's not working, what do we need to do, what do we need to do differently. And to me, that's a huge essential start to the process, where it doesn't necessarily require great resources or a huge investment of time, but that process itself has guided this community ever since that time. So we're in the process of building a new justice center. In that justice center, every conversation and how it's going to be designed, how it's going to be built, what its function is going to be, there's always a conversation, well, this is what we got out of our SIMS process. And so that's my pitch to all of you, to at least entertain the possibility as to whether or not you can or should go through that process. But through that process and through those conversations, we've also developed a multitude of ideas, some executed, some still ideas, but all of which are easily attainable, all of which are low-hanging fruit, all of which I would encourage your communities to consider whether or not there's something that you might want to do. So one of the things we realized is that in competency cases, for example, there's really no continuity among those cases. We have 10 courts in this district, 10 judges, and each of them handle their cases separately, alone. It's not coordinated. It slows down the process for getting evaluations. And so this week we committed to establishing a competency docket where all the mental health professionals will be present, the forensic navigators will be present, that there'll be a special district attorney, prosecutor assigned to that, special defense attorney, all working together to identify what the needs are and to be able to address those needs. To be able to accelerate the process of getting the evaluations done, where the Office of Behavioral Health will twice a month, because we'll have the docket twice a month, send somebody up here in the morning to do the evaluations, so that then the court component of the process can be addressed in the afternoon. My hope is that that will so improve the quality of care, the efficiency of care, that right now in our district, I've got probably 4 people on my docket that were found incompetent 8-10 months ago, some more, and they haven't even started restoration services. They're housed in the jail. They're not receiving immediate services. They are, I suppose, getting medication, so at least they're stabilized, but they're not improving. They're not getting help to address the reason why they're in custody. And to me, that's completely and totally unacceptable. But the way we can address it is if I'm dealing with one person here and one person there, there's no effectiveness for dealing with this. If we get that collaboration going where we can all work together, then we can be much, much more effective in addressing what the need is. But it is not sufficient just to deal with those cases where you have such a high level of concern that you are raising competency as an issue. We're trying to figure out what else can be done. And so one of the things we started doing in Lake County is gathering all different stakeholders, sheriff's department, the hospital, community mental health, substance abuse treatment, probation, and myself, meeting regularly to do two things. One is to do case management on individuals who are served by multiple agencies, because the agencies often don't talk to each other about what's going on with that individual. And that way we can better coordinate what that care plan is and also identify gaps for the individual. In addition, we do case assessments so that when we have an individual who has a crisis, we go through who contacted them, who processed them, where they were sent, where did they go, what treatment did they receive? Did they receive what they needed? What was the outcome? What were the gaps? Where were the breakdowns? Where were the successes? And to have those conversations among all of the stakeholders who routinely and regularly are working with these populations to improve how they can deliver services, how they can identify need, how they can hopefully present people getting further into the system if the need can be addressed immediately. What does that look like? We started having conversations because we developed a co-responder program in our community to figure out, wait a second, it's great that we have this co-responder program, but there's no collaboration with the courts. So they can respond to a call, the person still gets arrested, they come into court, the court doesn't have a clue of what that engagement was like, what that individual's need is, yet you had a professional who had that expertise, who had an engagement with that individual. One of the things we've developed is a report that on any case a co-responder comes out with law enforcement or the ambulance or whoever, that they will prepare a report that if that person does get arrested, the judge will be able to help understand better what the situation is. Is it a situation where that person is going to decompensate and get worse if they're even kept in custody for a weekend? Is it something where all they need is bond conditions to take their medication? Whatever it is, to be able to improve the communication among the players so that you can better meet the needs of that individual, to me is super, super important. Other ideas we've talked about is having, right now in court, there's always a victim witness coordinator who's present to assist victims in whatever their needs are. We've had communications dialogue with NAMI to do the same thing with people who have mental health issues, because if a family member comes into court, which happens very regularly, I called the police because I needed help. I just needed help and I didn't know what to do. My rote response is, you came to the wrong place and I don't know if what you did is really going to help. If there's someone there who has that sensitivity, who has that experience, who has that ability to work with that family, my guess is they will get the support they need. If that person gets the support they need, they can also better serve the person who they called about. To me, that's something which is super important. I don't know whether any of you are familiar with the Bridges program. The Bridges program is another program that was started by state judicial to have navigators that are hired by the courts and work for the courts generally, sometimes for one of the community mental health agencies, that are there to assist in mental health cases, primarily competency cases, but they can be appointed by the court wherever there's a mental health need. And that person's charge is to help that person with whatever it is that they need. If they have trouble getting a cell phone, just to even be able to make appointments or to be monitored, they'll help them get that cell phone. If it's transportation, they'll help with transportation. If it's getting a bed in a facility, they'll help with that. They'll help with whatever that individual needs to help stabilize them, to help make them successful. That's something which has been a game changer, and Colorado is one of the few jurisdictions that has such a program. We like that in Lake County, but that wasn't enough for us, because on the one hand, it's great to have that resource, but that only works if they make it to the court where there's a court appointment for that individual. So we started another program. We call it our concierge program. The concierge program is a program where we have someone who is hired and employed by our community mental health agency to be at the courthouse to help you solve your problem, whatever it is. And so they're there whether you have a problem with housing, whether you have a problem with food equity, whether you have a problem with a need for treatment, they're there to help you out. it's trying to shift thinking of even what the role of courts are from, I think most people, when they think of courts, think that's a bad place, that's a place I don't want to go, to shifting it to, I got a problem, there's going to be somebody in that building who's going to help me out. That too, as we build our new justice center, has been one of the central themes in what we call community justice. And so central in the design of our new courthouse is the person who's going to help you no matter what your issue is, to help you find what that solution is. That person is kind of a catalyst to get you to whatever service you need. But the design we have for what this program is going to, how it's going to operate, is that individual then can connect you to a kiosk where you can WebEx into community mental health, where you can fill out initial assessments, where you can complete applications for TANF funds. Whatever it is that you need, there'll be an opportunity to meet those needs just by showing up at the courthouse. That's been a process that we're really, really excited about, but we've really leveraged the relationships we've had with all sorts of community organizations to help them join in making this successful. And so if I have, for example, an eviction docket, to have someone from the local community organization that deals with housing issues to be physically there to assist people, the likelihood of them finding a solution when they're still in the building where their case has just been called or their case has been passed is so astronomically higher if the resources are there, are immediately available, and they're going to hopefully find some successful solution before the case is even heard or adjudicated, or better yet, not even filed yet. That's what we're looking to accomplish in the model we're using. There's been a lot of excitement about it, and in fact, there's a national meeting of rural justice advocates that are coming here next week to learn more about how they can adopt similar programs within their own jurisdictions as well. Other things we've talked about is advanced mental health directives, that the idea of making it so that if there is someone who is a frequent visitor to the court system or with law enforcement, to know who their providers are, so that rather than just simply bringing whoever's on call in to do a new assessment with that individual where they may not know that individual, to be able to connect them with the people who they already have that relationship with, who knows the struggles, who knows what might be effective as an intervention. Hope is that all of that is going to elevate the quality of care, the quality of response, and more precisely address what that need is. Even with, for example, that concierge person, on the one hand, we've designed it to help anyone. It's invaluable and has been invaluable over the last year to the courts, where I have someone who comes before me, he says, I finally realize I need to get help for my addiction. In the past, what would happen is the person would either be released and we'd hope he'd figure it out, or he'd be held in custody and have no access to be able to figure out what the plan is. What we do now is we pass the case, and 9 times out of 10, our concierge is able to find the person a treatment bed, usually for the same day. That saves taxpayer money and improves the outcome for the individual. It gets them their need, it meets them where they're at. All of those things are, to me, incredibly helpful. That for a lot of the individuals who are court involved, if they come to court and make it to the courthouse, that's remarkable in and of itself. To then put demands on them, well, you need to set up an appointment for behavioral health services, that's just asking too much. If we can know that when they walk out of here, they have that appointment, they have someone who will help them get there, they know where it is, they know what to do, the likelihood of them being successful is so astronomically higher. Again, that's something which we've accomplished because we get all the players to work together. And so if you are in a jurisdiction, even without a lot of resources, I would strongly encourage you to reach out to the bench, to reach out to the judiciary, to get them to work collaboratively, because we see it every day. And it sure is frustrating to us where we see the problem over and over and over again. And we like to think there's a solution, but we've never had the people at the same table to really talk about what those solutions are and to design those solutions and to implement those solutions. So that's kind of what I've got. I'm happy to talk about other questions. I mean, there are a million great programs out there. Some of the things that we've talked about trying to establish are transitional housing with supervision. We want to use some of the, there's a consent decree in Colorado where the special masters are receiving monies from $1 million monthly fine that Colorado is having to pay because of our deficiency in the quality of services. We're looking to use some of those resources to create community-based transitional housing opportunities for people. But it doesn't take big ideas. It doesn't take lots of cash necessarily, just a commitment.
Thank you so much, Judge Seamus, for sharing your work with us. I thought it was really important to include what the judicial-led diversion looks. Judges are such key figures in their communities that when you've got commitment and partnership from someone on the bench, as you put it, that can really help bring people to the table.
Contrary to what people think, judges really don't have a lot of power. However, when we invite you, most likely you'll come.
That's right. That's right. That's key. So including your judge partners in your diversion planning is a really great idea. Could you share a little update about the work of you had a group, I forget the name of it, but a group of rural partners that you were working with?
So I am part of the Rural Justice Collaborative, if that's what you're talking about. It's a national group that's convened by the State Justice Institute and the National Center for State Courts that's really designed to assist rural communities in trying to be successful in addressing justice needs, not just behavioral health, although behavioral health needs are a huge, huge focus of it. One of the things that if you are interested that they've done with the people who are part of the process, there are huge, huge funding opportunities out there that they are circulating, I think on an either bi-weekly basis or monthly basis. These are the opportunities for funding to provide support for your justice center needs. And I said with a huge emphasis, of course, on substances and mental health. And so for that alone, it's probably worth the price of admission, which is free. They also have a process where they identify innovation sites around the country. I believe right now they've identified 22. I know that there are several on the horizon, so it's going to be larger than that. And I guess there are two ways of looking at it. One is if you need ideas, great place to go to be triggered and say, hey, that's something that we need, that's something that we can do. And one of the things that we're committed to doing is making it so that it's not just recognizing success, it's also trying to make it so that there's a roadmap so that you can duplicate that success.
Great, thank you so much. Well, I don't see any questions in the Q&A. So I think that we're going to call it a day. Thank you so much for joining us, Judge Seamus and Veronica. And please note that this recording will be available on our website within the next week or so. And Judge Seamus, I imagine that you'd be willing to make yourself available to anybody who wants to follow up with you with specific questions.
Absolutely.
Great. Well, thank you all so much for joining us for our Rural Summit on Mental Health and Criminal Justice. And thanks again to the David and Laura Mirage Foundation for their support, and to the Lead Support Bureau for the great work that they do around the country and their support in putting this series together. With that, we wish you well, and thank you for being allies and partners in disentangling mental health and criminal justice.